Thank you. You clearly have an interest in ER and/or virtual care to be here at the last session, so thank you for that. And I hope you've had a good conference. It's been a couple days of kindred spirits for me, so it's been very invigorating, and I hope that you've had that same feeling coming at the end of the sessions here. So I am a practicing emergency medicine physician in Dallas. I do that about 3/4 of the time. The other half time, I work as a safety and quality officer for a group of about 500 emergency medicine providers in Dallas. So I will tell you, most of my perspective comes from that, thinking about safety and quality. There is in this very specific use case some deliberate thinking about what healthcare and acute care looks like 5 and 10 years from now for our group. So probably about 2 years ago, we sat down and started thinking about how do we as emergency medicine physicians fit in? What does that look like in the coming value-based world? And it started us along a path of developing some skill sets and tools and thinking a little differently about emergency medicine. And this particular use case is very much related to that. So let's dive in. We'll talk a little bit about post-ER virtual care, and we'll get through the slides as fast as possible so we can turn this into a discussion, because I'm very interested in your thoughts. No one is paying me to be here. I do have some ownership interest. Acute Care Transitions is really just a contracting entity for all of the good docs that do this work. And then I have a small interest in CirrusMD, which is a platform that we do this work on, and that's been a good partner for us. So there's our agenda. We'll touch base on acute unscheduled care in both North Texas and nationally, and it's sort of doomsday data from the front lines that you're all very familiar with, but we'll look at briefly, and then we'll talk a little bit about us sort of rethinking the emergency department visit and what that's meant to our group and how we fit in, and then we'll look specifically at some utilization and outcome data. The learning objectives are there. I think they're in your app, so you can take a look at those if you'd like. So setting the scene. So this is North Texas now. This is from the Merritt Hawkins Access to Care survey they do every 3 years in a number of large metropolitan areas. So this is 2017 data. So the number of days it takes to get in to see a family medicine physician in Dallas has more than doubled in the last 3 years. The number of physicians taking Medicaid has dropped by half. So we're down in 1 in 4 physicians taking Medicaid in the North Texas area. And so that creates really this, and this is national data. It's worse in North Texas, I can assure you, but it really means that acute unscheduled care for many people is happening in the emergency departments. This is not news, but that is particularly true for the uninsured. And not just their acute care, but really all of their care. And I put this slide in here not because it's breaking news, but to think about this from a patient-centric standpoint. And that is, there's a lot of gnashing of teeth over this data because it's an expensive point of care. So the idea of trying to get people out of the ER and into a medical home makes a lot of sense to me. But the reality is the ER is part of the medical home for large swaths of our population. And so those discussions around value and around medical homes, I think it's important to be thinking about the emergency room and aligning the providers, aligning the staff, aligning the sort of the visions, and not taking these sort of strategic, let's figure out how to threaten patients away from the ER, or somehow carve that out of our medical home models. Because the reality is there's a lot of good work and comprehensive services and convenience and access there. And so there's an awful lot of the foot traffic doesn't lie. There's an awful lot of acute care going on in emergency departments. If you're a health system, it's also a big swath of what you do. So this is a very large study out in the last couple of months. So this is the number of touches you as a healthcare system have with your patients and your consumers. And so really half of what you're doing is downstairs in that front door. This exceeds the number of your outpatient visits. It exceeds your admissions, your surgical suites. So this is often your touch point with your consumers. Once you've come in through the ED, what does it look like? You've had your acute care scheduled or unscheduled visit. What does it look like trying to get back into a medical home? So this is a study out in the last month or two that looked at urgent need to get into a primary care doctor following an ED visit. And these are the sort of numbers that they found. So for that Medicaid population, 1 in 4 able to do that, commercially insured 1 in 3. When this came out in North Texas, this quite frankly seemed high. And so if you deep dive the study a little bit, this is a study done in the state of Connecticut. This is what the PCP per population ratios look like in Connecticut. So they enjoy the luxury of being a top 20%, top 15% state as far as density of PCPs. We're very different in Texas, being near the bottom of the list. And that probably has something to do with why those numbers feel high to me as a provider. It's worse if you have chronic conditions, and so this is from an outcome standpoint. These are the folks that we absolutely need to be plugging in following, acute unscheduled care. And so again, national data, but 1/3 of these folks that we're trying to prevent revisits on, the diabetes, COPD, CHF, are not having any follow-up appointments following an ED visit. And then this is really the statistic most relevant to this talk and probably sort of my passion on this. And it's maybe not stunning, but it's a failure rate that is incredible to me. And that is that nationally, and this is 54 million ED visits, nationally 8%, 1 in 12 ED patients are back in an ER in 72 hours. That is a number that's amazing to me. And it doesn't feel like that as a provider, and part of that may be because 1/3 of those patients feel like they have unmet expectations, and so they go across the street. They're going to the competition. And so this recidivism, this cycling back through the ER, even in these short durations, 72 hours, obviously drives a lot of utilization and a lot of cost, and involves an awful lot of unmet expectation. Dr. Rising out of Jeff Health has studied and interviewed an awful lot of these patients, and I apologize for the long quote, but it's very insightful. This is their summary quote, and it really has to do with why are people coming back. It's because they're anxious about their symptoms, they don't know what else to do, and they've lost trust in the healthcare system. And I'm sure this is a crowd that probably is interested in the ER and knows this and feels it. And Dr. Rising's summary is we really need to be better as a medical community at meeting patients where and when they need it. And so as a person that's proud of a lot of the disaster work that's going on, ERs are often demand outstrips supply, and so I'm very proud of the work that goes on there, and there's a lot of heroes downstairs. But the reality is that a lot of that care is, transitions are unreliable, the care can be fragmented, and there is unmet expectation, as we discussed. And as a safety and quality officer, this is sort of what I feel, it's risk, and it's risk along the domains of safety and quality, and then of patient experience. So in thinking about this, and I came into the safety and quality officer role about 3 years ago, and we were really going through a time when we were reflecting on how we fit in. And so we really started to think along these lines, and that is, do we just need to be the episodic care doctors? Does it really make any sense that I'm seeing patients for 2 to 3 hours at a time with a 2 to 3 hour focus, and then turning them back into this morass of lack of follow-up and lack of continuity? And what if we just flipped the whole model and thought about relationships with patients that lasted some interval of time, the time that they were sick, that the acute care episode. And so the conversation at the bedside is no longer, hi, I'm Dr. Muller, what is your emergency? The shaming of the patient for coming to the ER when they didn't need to. Now the conversation really is very much about, hey, I'm Dr. Muller. I'm sorry you're going through this. We think a little different about emergency care here, and I'm telling you that we plan to be with you for the next week and help you through this and be there for you when you need us and talk about your transitions. And so our whole team here, from registration nurses to doctors, we want you to know that we're committed to you for this care episode. And so when you start to think like that, it's not natural. People are ER doctors for a reason. They're ER nurses for a reason. But when you start to begin that patient-centric discussion, it begins to really change everything. and it's a very different dynamic in the EDs, and we've had some EDs that have really embraced the concept, and it's very exciting work to see that going on. So we started small, and we took this on ourselves. So I'm an independent physician group with a bunch of independent physicians. We took this on as a value add, and nobody was paying us to do this. We were interested in doing this as a differentiator and as the right thing to do, and as I mentioned, developing some skill sets that we hope to use in the future. So we did this. We basically put our own ED physicians on call to the patients. And so the model is if I see a patient in the ED, I may not be the one interacting with them after the week, but one of my partners is. And so we have physicians that are doing exclusively this. Most of the time they're not working in the ED. This is their role for the 3 to 4 hours or 2 hours or 6 hours that they do it. So we have made ourselves available 24/7. It's us, it's our group, and so it's all doctors that staff the service. We all are credentialed in the hospitals. We all have access to the EMR, and we've made ourselves available to the patients for a week following ED discharge. We didn't know anything about telehealth when we embarked on this, so we had no feelings about video or audio or texting. This was just about how do we communicate with patients? How do we make ourselves available? We knew a couple things. It didn't make any sense to charge for it. That completely undermined the entire point. So we weren't going to charge. It needed to be easy to use. We wanted it to be familiar to patients, something they sort of knew how to do and thought would be easy to do. So texting sort of seemed common. Most of my disenfranchised, even homeless patients have cell phones. They come in to recharge them all the time. I'm sure everybody has seen that. So this was something that was relatively available, and of course, we needed a HIPAA-secure way to do that. So that's what we did. Went on call for a week for ourselves. And so let's take a little bit of what that looked like. Now, we started that very slow. I had no idea what was going to happen. I didn't know if this was going to be about, like, I need a new meal, or my wheelchair's broken, or can you help me find a place to sleep, and so we didn't know. So we started in 1 or 2 EDs, and then we have been adding emergency department at a time over about the last 18 months. And so this is where we are today. So we've had, since September of 2016, we've now done about 8,000 encounters. The asynchronous nature of this, the ability to sort of text in and text back, we have everybody come in text first. We use a platform that's fully capable of video, audio, texting. It does all of it. But we have encouraged people to just come on in knowing something that they know how to do, which is text. And so our response times have been good. We've been able to maintain this sort of very short turnaround. So it's kind of 65 to 90. I think we're actually well below this now, but it's a minute to a doctor. We find that in that week, a lot of people re-engage in the service. So we have about a third of our patients that are using it a second or third time during the service, during the week that we give it to them. The nature of the encounters is interesting. That 42 minutes is probably scary to a lot of people in the audience. But that's because we think about it in a physician or health system-centric manner. When you're the patient, you're now thinking, wow, I just had access to that physician for 40 minutes. The pace of the conversations is occurring at the pace the patient's interested, and not that I am, as a physician or a health system, interested. So instead of forcing somebody into a sort of 5-minute video chat and then moving on to the next one, we allow them to come in and engage sort of at their pace. So that's really kind of where we end up. Some of them are a little longer than that. Many are shorter. But on average, the conversation lasts about 40 minutes. Now, that's not 40 minutes as my time. I mean, this is 7 to 8 texts on average. So it's 180 seconds of my time, but it's spread over 40 minutes. And so from a patient feeling standpoint, the conversations, again, they're paced at the pace that the patient is interested in, and so it feels like we're not rushing them. We have found very little interest in moving to audio or video in these encounters, either from the patient or physician side, so we stay text-based, asynchronous largely. And I'm using the word asynchronous because it's text. Honestly, there needs to be a new term. So this is near synchronous or something. I mean, this is real-time text chatting. It's not synchronized in the state legislature definition of audio-visual, but I'm having interactive human communication in written form, and it feels very synchronous. And so that stays text-based about 97% of the time. I am now to the point where I'm pretty comfortable, just like my 12-year-old daughter, of having multiple conversations at the same time. So it's very easy to maintain 4 to 6 patient encounters in parallel. I actually am pretty comfortable doing that at 8. It really depends upon the intensity of the people you're interacting with. Other groups that are doing this, Kaiser's now doing this on a very grand scale, believe that somewhere in that 4 to 6 encounters at a time is the sweet spot. And so we staff according to sort of that demand, and the ability to sort of handle those utilization volumes around that sweet spot of 4 to 6 encounters at a time. We have done like zero marketing on this. I mean, this offering the program is done in their discharge paperwork. I'm sure most of you work in and around ERs. You know that most of the discharge paperwork end up in the trash can in the parking garage. So we have put it up on the front page to try to give it a little bit of attention, but we have not infused sort of any capital into marketing this thing. And this is the utilizations we're seeing on average in that model. And so it's 3.5% to 4% on average. Interestingly, when you get an ED that's particularly excited about this, so where registration or nursing is talking about it, on that discharge discussion, or heaven forbid the doctor slow down for 15 seconds and hey, and I'm a true believer, and we've got now 40 to 50 physicians that work on the service that are true believers. So my discharge discussions now are very much about, everything looks good today. I am concerned about your safety, and so I want to be available to you over the next week. And that foot is red, and we're going to put you on antibiotics, but let's take a picture of it right now with your phone on this platform, and I'd like you to touch base with it again in 12 hours. And it literally has changed how I practice emergency medicine. And so when you have that sort of engagement from your provider team, we have EDs where utilization now is approaching 10%. Our age groups look a lot like many of the telehealth distributions, and this has been shown a couple times this week. We're getting the AARP members to use it. I had an encounter with an 86-year-old the other day, and I thought for sure it was his granddaughter or somebody, and he was totally offended that I inquired whether it was really him or not. So we're seeing it out there, but of course the big adopters are the Generation Zs and the millennials, and so we have sort of a peak there. Why that's particularly interesting for me is those patients, that age group, is historically very unsatisfied with emergency medicine care. So across the nation, those are your lowest Press Ganey scores. And so now we are interacting in a way and doing service recovery and establishing relationships with, quite frankly, the group that scores us the lowest. And so we've seen, and this is not surprising, but that technology is a way that they very much like and are interested in re-engaging with their healthcare providers. Our time of day curve looks like every other emergency department in the country. It just starts a little earlier. So instead of having to make a decision to not go to work and get a ride to the ER and park and come in, and so picking up at 10, we tend to pick up at 7 a.m. when everybody wakes up, and it stays pretty flat until the deep night. And we have a trickle of stuff at night, but most of it is when people are awake. So a few words on outcomes. For all of the work we do, we really try to frame it up around the quadruple aim. And I'll be honest, when we started this program, it was very much about safety. It was safety and quality focus, laser focused on safety and quality. I went out of my way to say that we weren't going to be trying to build ROI curves on this, that this was really a value add, and it was patient-centric, and that was the purpose of the program. No, I was naive. There's always a CFO in the room, but that's how we started. So our focus was very much health outcomes. We will talk and are now starting to do some analytics around this experience, and so we'll talk about some of those other domains here. So from an encounter resolution standpoint, this is what we see. So about 85%, and this has been very consistent now for a year and a half, about 85% of the encounters we feel like on our end of the deal that we are resolving the issue. So at the end of the conversation, it feels like the question has been answered. And about 15% of the encounters, it feels like they need to see somebody else. And we're an emergency medicine group. That's where we are. So as we kick this model off, it was not a clinically integrated network approach. It was about safety and bringing people back in. And we see an awful lot of embryonic disease in ERs, so a lot of things that are abdominal pain that turn into appendicitis. So we tend to bring people back. Now, if you were doing this program as a healthcare system or as part of a clinically integrated network, you wouldn't have to bring them all back to the ER. But currently in this use case, we tend to send them back in for reevaluation by us. And so that's what the kind of the broad swath. Now, we have recently done a big deep dive on our health systems electronic data warehouse, and we have learned that, interestingly, our numbers are spot on. So 86% of the people we interact with don't come back, but it's not the exact 86% we thought. So it turns off we're about 5 to 8% off. So 5 to 8% of the people we thought were not coming back are showing up, but 5 to 8% of the people we sent back in are not showing up. So the division is still 85%. It's just not the exact same 85% we thought, and that actually makes probably perfect sense. Within those groups, there's some other divisions there, and so of that 85%, about 15% of the people we interact with, we prescribe some additional therapy. And so from a safety quality standpoint, that feels like treatment failure to me. It's people that come on and needed some additional therapy, and so we do that through this program. You can see that the vast majority of this doesn't get any additional pharmaceutical therapy. It's largely reassurance and advice. And then in that return to the ED slice, we've now looked, and we end up admitting about 2% of the total patients in this program into the hospital. This is survey data of the physicians on the platform. So at the end of the encounter, we asked them, what was this? What was the conversation about? And they feel like about 85% of the time it is medical advice that they're providing. There are some people that come on and look for test results and have administrative needs, and some of this we feel like is service recovery. They just come on and they're just not really happy, and they want to talk to unhappy, and they just want to talk to somebody about it. But this felt good to us. We weren't sure what this was going to be, but this was going to become a care management program staffed by doctors, and we feel like we're delivering an awful lot of medical care on the platform. I mentioned the fact that we do some additional prescriptions. Anytime you run a telehealth service, you worry, or any kind of additional follow-on service, you worry a little bit about becoming an analgesic service that they didn't get in the ER, and there is some of that. So of that 15% slice, maybe a little bit less than half. So we're in the sort of 5 to 6% range gets some form of additional analgesia, and then you can see the other categories of medications that we're prescribing on that small slice. And then finally, this is sort of why we started the thing. So this was when we send people back in, what does it look like? So this is all done with physician-to-physician handoff, so we don't text, go back to the ER. It's very much Mrs. Miller, I'm calling Dr. Smith now. He's going to be expecting you. I call Dr. Smith, and Mrs. Miller's coming back in. Her abdominal pain has gotten worse. She didn't get a CT scan. And then on arrival, Mrs. Smith hears from Dr. Miller, we're really happy you came back. I talked to Dr. Muller. I understand you guys have been interacting. Thank you for coming back in. So it's very much a concierge, white glove, warm handoff for these patients. And you can see we have, several hundred now of these patients that have very real disease. And this is not bad emergency medicine. This is just emergency medicine. And this is stuff that was started early and got a lot worse. And now we're bringing these patients back engaged in a model where they're not mad at you because you missed it, because they've stayed connected with you, and they come back in and they feel like you're there for them. And so this has been for me the big win, and these are the ones that we're awful happy to still be involved in their care and have gotten them into the right places, and they're not across the street. So in the experience domain, when you do something new, when you exceed expectations, usually your experience data is pretty good. And so we have found that this is not something that people are used to, and so our promotion scores have been pretty high. It's the testimonials that keep us all excited about this. There's an awful lot of, and I have pages and pages and pages of these now, but they use words like care, listened, concerned. It really differentiates because we're taking our time and they feel like we're there for them. This is a little more survey data, now kind of moving out into that CFO value realm that I said I would never do. So the patients get a survey at the end of the encounter, and we've had a pretty good return rate on those surveys. This was an analysis that was done after about 800 of them. And so we asked them if they had not engaged with us, what were they going to do? And so there's all kinds of stuff here about going to urgent care or looking up something online. But those two orange slices say I was going back to the ER. So one was the same ER, and the smaller, darker orange is going back to a different ER. And so that 55% has been a very solid number. It really hasn't budged at all. About at least half of the people are telling us they were going back to the ER, and that relates back to that really high frequency of people coming back. And so maybe it's half of the number. I mean, it is survey data, and it's only as reliable as all survey data. But a lot of the people interacting with us are telling us they were going back. And now I'm going to really go out on the limb. But if you plug sort of fair health data into the value of these folks that we're going to go back and now feel like they've had their issue resolved. So, obviously now you're starting to talk about ED diversion. Anytime you divert people from an ED, the numbers add up very quickly. And so, we think in the now 8,000 patients that we've interacted with, that if you plug in fair health values to physician charges, fair health values to the facility charges on these sort of typical ED visits, the numbers get very big very quickly. This is all abstraction. We're interested in doing some claims-based assessment of this and moving that direction. This program is not payer-specific, so there's no one interested party from a payer standpoint. We're sort of seeing everybody. So a lot of this work is going out and trying to partner with those folks that are at risk for these patients and talking to them about what you're doing. But we've started some of that journey with the health system that we're working in. And this $20 patient per discharge is not the patients we interact with. This is really that number divided by the total number of patients we saw at those EDs. So we think we're in the $20 a patient discharge kind of value realm if you believe the number of people that were coming back and the sort of typical fair health values. And then this final category of the quadruple aim is really one that is a little bit surprising to me, but has been very rewarding. And that is that of those 500 providers, I now have 40 to 50 emergency docs that are true believers. And these are now this is the callback program on steroids. So this is the physicians that are now participating in longitudinal care. They're learning about disease that progresses. They're learning about their partners that don't give antiemetics with Flagyl. They are learning about the dissatisfaction, the morass of going to a pharmacy and having that antibiotic not be covered by your health plan, of trying to get into it. So all of this stuff now is coming back into the platform, and so we've got docs that are interacting with these folks. And so now the physicians that are leading the discussions in the QA meetings are these docs. I mean, these are our engaged super providers now. And there are wins throughout here. This is obviously way too small to read, but this is an interaction of a single mother of 3 who chose to go home with her urinary-based sepsis because she didn't want to bear the cost of the hospitalization. And so this was a physician interaction that occurred the next day, unprompted. She came back in and said, "Hey, listen, I just want to tell you guys that I feel a lot better." And she actually we were able to sort of hook her up with the doctor that she had interacted with. And this guy happens to be the president of our company. And this is not a tearful guy. This floated his sales for a month. And he just felt really good about this interaction. And man, what a win. Talk about a sort of a solution for burnout. And then we get lots of testimonials that are fun to send back to the doctors. So this was one. This is not quite HIPAA compliant, but this very nice lady said that she printed out her encounters and shared it with all of her breakfast friends. And so that's awful fun to send that back to the doctor. And again, talk about sort of filling sales. So I didn't really think ahead of this, but I think we probably are touching sort of all of these domains now, and we're excited by that work. We're excited about this sort of shift in thinking toward episodic care. It has, scaling this up, of course, comes with cost, and so you have to really think through that and who your partners are. But it has been something that we're very excited about, and we're continuing to work on and continuing to grow. So let me just close, and then maybe we can have some time for questions. So I spend now a fair amount of time talking to IT departments and CIOs and partnering with our healthcare systems. And so my sense of this, and this is not shocking, is that really what are you doing when you design these interfaces that relates to delivering care? And for me, that's become the litmus test. And it's nice to have parking garage maps up on your app or be able to look up a CBC, but how are you providing additional access to care with the programs you're rolling out? And that's become sort of my litmus test for thinking about things. And then if you're going to invest, I really believe, and this was said at the last session in the main hall, it's really about building relationships and trust. I think that's where investment needs to be going. And so the kind of programs that we're spending time and energy on are really about that. It's about the patient-provider relationship, trying to get everything else out of the way and building those relationships. So that's all I had. Let's see if there are any questions. I think we've got a little bit of time. I realize we're at the end of the conference, so you won't hurt my feelings if we don't have any, but I see a couple of hands, so let's go ahead.
First question, which app did you use?
Sure. So we are using the CirrusMD app. It's Cirrus, CIRUSMD. There are a number of apps out that could do this work for sure. Cirrus is a group that was interested in partnering. They really changed their flow models for us. So they were interested in working with us. They're a group that's very focused in the value realm, and so it was a good fit, and they've been a good partner for us. Yes, those are statistics that are a little hard to prove on the total volume number. Where I'm sure interested in showing that, and now that we have the tool available to go look in their data warehouse that looks specifically at these patients and whether they came back or not, I think we have the tool to show that. But it's all about measuring the value. It's measuring the value of the visit that no longer happens. And so you have to sort of take this leap of 8% were coming back, and now we're interacting with 8,000, and of those, most of them said they were coming back. And so you kind of get that way. Showing an actual decrease in the return rate because the volumes are so high, so we have only 3 to 5% of the people using this thing, has been a little hard statistically. There's no doubt in my mind that we're answering. People tell me all the time on the platform, thank you for being here. I don't know what else I would have done. I was going back in. And so I think we are hitting on that metric, and that's ROI. Like everyone else, the blues are a big payer source, and I sort of joke all the time. I'm doing an awful lot of ROI work for Blue Cross Blue Shield right now, I think we looked recently. Probably 20% of these patients are Blue Cross Blue Shield, and so we are interacting, and there's no doubt in my mind diverting additional ER charges. Yes, sir. Oh, ma'am,
sorry,
I'm sorry.
go ahead.
Yeah, hi.
I just wanted to ask, you said that 3 to 4% are who you pick or who use it. How do you pick those people?
So actually, we offer it to everybody. So everybody on ED discharge gets a small description of the program on their ED paperwork, and it says, we are concerned about your safety. Should you have any additional questions or need to re-engage with your physicians, go to the following website, and they go through a short registration process. and then they can either via web or app basically start texting with us.
Okay.
So everyone gets offered it. We have what we find is somewhere in the 3 to 5% range of our discharges actually utilize it.
Okay. And you said that audio and visual isn't something that you incorporate. Is that more for the provider that
So
it's-
we have it available. So the platform does audio, visual, does all that stuff. We just find that most people like to text.
Okay. So I
And
was
it-
just curious if it was the provider that had the preference to text or if it was the patients.
Yeah, so I would say both.
Both?
Both. So either one can go live on audio and visual. They just never want to.
Okay.
And I'm not here to. There are ongoing debates about this topic. I'm not here to enter into that debate. I will tell you there is no doubt in my mind that the written word is a valid way for humans to communicate. This is not shocking, and that an awful lot of medicine is about the story, and particularly post-ER. And so we have found, and we feel very comfortable. I mean, I have something like 1,500 of these encounters myself now, that I feel very comfortable in being able to interact around advice and history. And when I need to look or talk, then I do. And these are, this is new for us, so these are relatively conservative practice patterns. These doctors are not taking risk on the platform. There's no way they're going to subject themselves to risk for this relatively low-paying program for them. So it's a conservative practice of medicine for sure. And occasionally I think I can add a little bit by seeing a child that's breathing quickly, so those all go to video for sure. But most of this is conversation, description, advice, and I'm a big believer that the efficiency that comes across by deliberate texting, so there is a pause, you type in or voice dictate and you hit send. It's very interesting how efficient that communication form is. As you see, our average, it's 7 texts is our average encounter.
Okay, so last question, but so do you have, so on those encounters, so you go off shift and let's say there's another text.
Yeah.
So does that conversation continue
Yes.
seamlessly between multiple providers?
Yes. So the way the platform's set up is you can just basically scroll through the conversation. We write progress notes. Those progress notes are readily exportable to whatever HIE or Epic or where you'd want to stick them. But so when we get to a natural stopping point in the conversation, we write a progress note. It's a free text, typically just sort of summarizing what we did. We try to structure it around typical, but we don't have forced fields, like we don't have a review of systems for these encounters. But we do ask the providers to write a note, and then when they write that note, what's most important is we collect a lot of information from the physician. So what was this about? Did you prescribe a new medicine? If so, what was it? And so we can do some analytics around the work that we're doing at that point. And then if they come right back in 2 minutes later, it just picks back up the conversation stream. It brings it back on as an active encounter. And I can see the entire conversation from what would be the prior provider.
Okay, I lied, it wasn't the last question. So based on what the types of questions, do you feel that other people besides physicians in ED can be monitoring
Great question.
those texts?
So, full disclosure, the tool set that we built has led to other use cases. So, for instance, we're now involved in a population health flavored collaboration between a health system, a payer, and us, where we're a member benefit. And in that integrated model, on the platform, we're now building in other disciplines. So, pharmacy, pediatricians, care coordinators. So it is very easy once you engage, and I think KP was just sort of presenting this at the last meeting. So now you're building it just as an engagement tool, and you can sort of quickly route and bring in as you need them other disciplines. So from the acute care piece, I'm a little partial to the rapid triage decision making that emergency medicine physicians do every single day. I mean, the one thing that ER docs are good at is sick or not sick. I mean, that's just all we do all day long. And so this is a little bit like the Israelis have been doing their disaster management the same way since as long as they've been talking about it. They take their most senior trauma surgeon They don't let them operate. They stick them out in front of the hospital. And they take that expert at the point, and they use them to sort and route and make the best, most informed decision about whether that person needs resources or not. And I view this model a little bit like that. So take your best experts at rapid assessment, triage, sick, not sick, and then layer behind them mid-level providers, nurses, pharmacists, all the various disciplines that are important. I like the model of putting that ER doc out in front of the hospital virtually, allowing them to interact and help patients make good decisions about what the next steps in care are. Of course, you could do this with family practitioner, internal medicine, mid-level providers. I would want people that are sort of in the business of making those rapid triage decisions every day, because those are the people that are really good at it. And, oh, by the way, are comfortable. So there's an awful lot of people that if you hear the word chest pain are going, the next phrase is going to be go to the ER, as opposed to asking 3 more questions about the chest pain. And so the emergency medicine provider group, whatever their training is very good about sort of a tolerance for a few more questions. At least that's what we found.
Doctor, you had one slide
Yes.
on kind of satisfaction level over age group. Have you followed or tracked the acceptance by age group of the people that take this home?
Yeah, so no, that's a very interesting analytic. You just gave me something else to do. So this is our utilizers by age group, but what we need to do is weight this you're saying weight it by the people that we actually offered it to.
Right.
Yeah,
You've got a great NPS score.
Yes,
86%.
and then now the problem with our survey, not problem, we made a deliberate decision to survey anonymously, so I can't actually relate back those surveys to the specific patients. Unlike, you can I think Press Ganey allow you to track back, but that may be something we want to consider doing differently, because it is pretty powerful to know who it is you're getting survey data from, for sure.
Or even just age group would be great.
Yeah, or by age group, absolutely.
Yeah. All right, thank you.
You bet.
Quick operational question.
Yes, sir.
So the physicians that are taking these calls, they are not clinically active. They are
Right, so,
out and about doing
with-
their daily routine.
With the caveat of, like a lot of mid-sized groups, we staff some super, super slow EDs,
Okay.
like 3 patients in 24 hours. So that provider, we absolutely will let staff this service at the same
Okay.
time. Vast majority of our physicians do this. We never let them, at our busy EDs, we don't let them work simultaneously. You just couldn't do it. I mean, it's busy enough that you have to dedicate some attention to it. You don't have to be dressed up in a white jacket. You can do it from home next to your pool, but you got to spend some time on it. So I would say 90% of our staffing is a physician that's doing this, typically for 2-4 hours. I find I don't even want them working any longer than 4 hours, because they lose interest. Becomes monotonous. So I try to keep the shifts short. A typical shift for our physicians is they'll do it either before or after an ED shift. So that becomes their clinical day. They make a little extra money. They have to go to the ER one less time a month.
That was my next question, the compensation, because I work in a small health system with 3 EDs, but we're all hospital-based employees.
Yep. Yeah. So you have to figure out how to pay for it, and sure, there's tons of carrots and stick ways to do that. There are, I know for sure, a physicians group in one of the hospital systems is doing a similar thing, where they take their sort of non-filled primary care doctors and obligate them to do a little bit of this. I think there needs to be a little bit of a carrot. I said this one other time from the stage, so I'll make the mistake of repeating it again. It turns out that you can pay ER doctors a lot less than you normally pay them to staff this kind of work. Stunningly less, in the 25% range. So it's amazing what, I think this really adds to physician capacity, because you're allowing people to come in on their own terms for very short periods of time and not get in a car, drive somewhere, get beat up for 10 hours. And so we have found all kinds of untapped capacity to do this kind of work because of the virtual nature, because the technology can bring them in and out very easily and allows us to track them and pay them very easily. And so I think there's a force multiplier effect here that's very interesting to me.
So I assume most of the time they're probably at home or some other desk setting where they have access to the medical records and they can review
Yes,
labs
I
and
may or
notes
may
and-
not have been working a shift here at ATA yesterday, for instance.
Okay, thank you.
I assume that the ER docs that are working this process restrict their evaluation to only what was seen and evaluated in the ED, although patients may, in fact,
Yeah.
ask about refilling hypertensive medications. et
Yeah,
cetera.
so we very much, and again, it's, you do this as compassionately as possible, but we try in the messaging to describe this as a continuity of a care related to the ER visit when we register them, when we talk to them about it. But if they come on the platform and now it's about an unrelated issue, we go right back to that messaging, and we've actually provided some dot phrase scripting to help physicians with that. Like, we're really here to address and answer any further questions that are related to what was going on in the ER, and it's free medical care, so of course we have people come in. It's a smaller percentage than I expected, but we generally will, as much as possible, try to route those folks off to their primary care physician if they have one. It doesn't feel great doing that, but it's just, it's scope creep at that point.
One other question. Did this require any changes to your med-mal?
Yeah, great question. And I
Insurance.
wish I was smart enough to anticipate the question back from our carrier, who said, are you calling to ask for less of a premium because this is such a risk reduction for you guys? And I said, no, but I wish I thought about that before I called you. So they thought this was for our group, would bring down our risk profile, and for our individual doctors was so much less risky than what they do every day. They honestly thought we were out calling to ask for less money or less charges. So, all right, well, thank you very much, and I very much enjoyed the questions.